Good morning, clinical problem solvers. Good afternoon, clinical problem solvers. It's Tuesday, it's Neurology Virtual Morning Report. And as some of you may know, and some of you are participating, this is not a sanctioned American Academy of Neurology event, but it's the American Academy of Neurology virtual conference this year, which is amazing because it means you don't have to fly anywhere or pay for an expensive hotel to go there. And I've seen a lot of our CP solvers neurology VMR friends participating thanks to that wonderful program where students can attend for free. And this means now students from all over the world can attend for free. And I have seen people based on their Twitter feeds having fun checking things out, from neurology education courses to inspiring lectures, a lot on neurology of COVID and health equity in neurology, health disparities, and then fun things like the neurology of video games and things like that. So those of you attending and taking a break for this unofficial but contemporaneous event, thank you for joining us. And we'll go from here. So you know the routine. We will need two discussants to discuss a neurology case and someone to present a case. So do we have any volunteers to present a case? And most importantly, because we can always find cases if we need, do we have two discussants, ideally one identifying as a woman and one identifying as a man, to discuss a neurology case today? Please volunteer soon. Some folks on this call are eager to get back to the American Academy of Neurology meeting at 1 p.m. Eastern. The first all-women's team leader to climb Mount Everest, who is not a neurologist, but is giving an inspiring lecture on leadership and teamwork to the meeting as sort of a special lecture. So that will be right at our end time. So some people might be eager to get back to that. So please don't delay them and volunteer to discuss a case this morning. Two volunteers. Maria is advertising as a frequent participant. Who would like to join us? Someone might be thinking, well, I'd like to, but it's neurology. I'm not that comfortable in neurology. That's a great reason to do it. You'll become more comfortable by discussing a case in this fun and safe learning environment. Some might be thinking, English is not my first language. I'm not sure I feel comfortable. Don't worry, hablamos español. We have people who speak Portuguese. We even have people speaking many other languages. There was some French last week. We learned, I don't know if Robbie is here, that I knew that he spoke French and Arabic, but also Urdu bol rahe hain. So we have many languages represented here. Anyone like to volunteer? I see some who have volunteered in the past, so barring that, I know some wanted to participate last time and we said, no, we want new folks. So anyone who's played along in the past, you want to join again, you're more than welcome. Anyone? Kirtan, fantastic. Anyone like to join Kirtan? Obviously, ideally someone identifying as a woman to join him. If no one else volunteers, I think we're at that point. Kirtan, you're in the seat. Anyone else? Anyone else like to volunteer? I don't want to cold call anyone, but I know people who probably want to, are thinking they might like to. Anyone? Don't leave Kirtan all alone. Anyone? Our numbers are growing, we're above 30. If no one else jumps in, Maria's, I think, our most frequent discussant. So maybe you will inspire some others to want to do this next Tuesday. Going once, going twice. Should we have our repeat amazing team here of Maria and Kirtan, or anyone else like to join in? And nobody has a case. So Gabby and Rafa, we will have a case from Brazil, from one of you. I'll let you decide who's gonna present. And while you are deciding that, Maria and Kirtan, well known to this as the star neurology team, but if you want to just quickly introduce yourself, then we'll get started.
Hi, everybody. My name is Maria. I'm a last year medical student in Guatemala, and I love neurology, so I'm really happy to be here. Yeah, I just finished a 24-hour night shift, so please cut me some slack if I say something wrong, but very happy to be here.
Someday you will be discussing neurology cases after a 24-hour night shift, so this will be good practice for that. Kirtan, do you want to introduce yourself again and remind us where you're joining us from?
Yeah, so I'm excited to be here back. I'm a final year medical student from India, and it's my first time discussing with Maria, so I will be glad to see how it goes.
Great. And remind us what part of India you're calling in from, Kirtan?
Yeah, so I am from the state of Gujarat, which is the westernmost part of India. And funnily enough, we speak Hindi, and as you alluded to earlier that Urdu, you spoke few words in Urdu, and Urdu and Hindi are very close to each other. So it's very nice.
Yes, I studied Hindi and then later learned that just writing different characters, it's more or less similar language, except in the most strict sense. So, hum bahut buriya hai aap yahan hai hamare saath. Okay, fantastic. Who's going to be presenting a case to us this morning?
I'm going to present.
Gabby, fantastic. This is an all-star neurology triad right here. Kirtan, Maria, and Gabriella. Great. And Sukriti, Rafa, you're going to help us with scribing, teaching points, all that good stuff. I think I haven't seen Kiara. Okay, great. What's the chief concern, Gabby?
Yeah, I'm very excited to be here. So the chief complaint is impairment of speech.
Impairment of speech. Maria, do you want to, I know you love language and languages. Do you want to start thinking through this chief concern?
This is going to be so much fun because we got to hear tons of languages from the get-go with Aaron, and now impairment of speech. This is interesting because, it doesn't really pull me anywhere, right from the start, because I know that when I started in med school, it was Broca's area and that was it. And then now speech actually has several components. So, it's first, perceiving it and understanding it, and then that has to be intact in order to then start having a thought and then verbalizing it. And then there's that is higher functioning areas of the brain, but then you also have all of the motor functions, so that sometimes we see somebody that has a slurred speech, and then right at the start we have MCA stroke, but then maybe he's missing even some teeth, or he's just having something more motor other than really cognition or languages. So I wish it could pull me somewhere right from the start, but it doesn't. But this is interesting because evaluating languages is very hard, and so always having a baseline of what the patient has, that is always from the start. You always need a reference because maybe he's just speaks that way forever, or something like that. And then always the time course is really important, as we've learned. Impairment of speech through years and years is common, and then we always have a ton of affection for our grandparents because they speak a certain kind of way, and that is nothing pathological, and it's taken years, and or it can be really sudden, and then we'd be thinking something vascular, or it could even mean something, speech as a part of a bigger picture of higher functioning components, or encephalitis, or altered mental status. So yeah, really fun CC.
Maria, oh my goodness, there is nothing left to say. That is a phenomenal discussion. I'm just going to pick up on a few points to highlight them and maybe ask you a few questions as well. So you made the really important point with which we have to start. And that is this a problem with language or a problem with speech? In other words, is this a problem with the cognitive aspects of formulating what you would want to say conceptually, or formulating the motor plan? Or is it a problem with understanding what is spoken or read? Those are problems with language, right? A cognitive function. Or is this a problem with the mechanical aspects of speech, the motor aspects of speech? And these two different problems, I think you alluded to, but have different names, right? So what would we call the problem with language versus the problem with articulation? Those would be what would be their technical names.
And so I think the first one would be like aphasias, and then the second one would be like dysarthria.
Fantastic. That is perfect. And I know you knew that and just wanted to put it on the record. So aphasia, right, versus dysarthria. And aphasia, we know, is a brain problem, right? We have a problem with language itself. This is a cognitive problem. But dysarthria, as Maria mentioned, can be a problem in a number of different locations. We know we're above the spinal cord, right? Because we're doing something in the head and neck, right? So we're brain, brainstem, cerebellum, cranial nerves. All of those are fair game, because once we make that plan of what we want to say in our frontal lobe, and we get it to Broca's area, which is probably starting to formulate the grammar of that utterance, and we got to move it into our premotor areas to make that motor plan that then go to the motor cortex to actually send them to our lips, tongue, face, jaw, larynx, pharynx, all those things that are going to move to actually do the things that are subconscious to us. We don't have to think about, how do I make the letter O, right? How do I make the rolled R if I'm trying to learn Spanish, right? Maybe you have to think of it in your second language, right? But not in your first language. Those are things that just happen. And that motor process does require the brain, cortical motor regions, the corticobulbar tract, which is the corticospinal, similar to the corticospinal tract, but bulbar meaning running to the bulb, which is the la bulbe, French for the brainstem or medulla. But those are the upper motor neurons for cranial nerve nuclei that are going to control the muscles of the face, jaw, larynx, pharynx, et cetera. So the upper motor neurons for 7, for 9, 10 that are going to help us move the mouth and the larynx and pharynx, and then those cranial nerves, right? And then we also have the lesions of the cerebellum, can also call the so-called scanning dysarthria. This is essentially ataxia, right, of the actual vocal apparatus, where there'll be variations in the so-called scanning speech, variations in volume, sort of as if you were taking a radio dial and turning it up and down while that person is talking, because they can't sort of control those aspects. So as we get to the exam, we'll be able to distinguish those, but we're sort of, when we talk about weakness, right, a common chief concern in morning report, we say we could be anywhere from the brain all the way down to the muscles, right? Here we can be anywhere from the brain all the way down to the muscles as well, but of the face, right? Because even a simple Bell's palsy, right, if half of the face is weak, right, then the aspect of moving the lips on that side will be altered, and there can be dysarthria. And then Maria made the very important point that the vocal apparatus can be affected not just by neurologic problems, right? And I've definitely gone on pre-rounds and woken up an older patient whose mouth is dry from not drinking overnight, whose teeth are out, and I think, oh my goodness, they're so dysarthric. Did they have a stroke in the middle of the night? And then they take a sip of water, put their teeth in, and you say, oh no, it's okay. They're talking normally, right? So we have to make sure this is actually neurological. But aphasia versus dysarthria, aphasia has more specific localizations we can get into. Dysarthria could be anywhere from the brain, brainstem, cerebellum, cranial nerves to the muscles of the face. Great. Kirtan, anything else you'd like to add here for this chief concern? Particularly,
so I guess, I guess you and Maria discussed almost everything. So I will now just point out a few things that, now talking about the aphasia, now we can break it down into like Broca's aphasia, Wernicke's aphasia, global aphasia, conduction aphasia, and there is something like anomic aphasia, transcortical aphasia. So, and how can we differentiate them? So on physical examination, as you mentioned, that we will see whether the patient can repeat the words. So repetition is the key here, because in some aphasias, repetition is intact, and in some aphasias, repetitions will be lost. Apart from that, I will be eager to see what other symptoms the patient has. Sometimes what happens that along with the impairment of speech, patients have difficulty in recognizing the faces, right? So something like prosopagnosia. So we have to consider the tract which is coordinating between the occipital lobe and the temporal lobe. Sometimes what happens that the occipital lobe is not able to relay the signals to the temporal lobe, the Wernicke aphasia part, so that our body doesn't know how to pronounce certain things. how to interpret certain things. So that's the one way to look about it. And then, of course, as the Maria mentioned, that what about the time course? If this is a chronic process indeed, then I would like to see whether the patient has Alzheimer's disease, whether the patient has frontotemporal lobar dementia, because FTLD can present with 3 forms of aphasia, like non-fluent aphasia, primary progressive, semantic form of aphasia. So that is like Broca's and Wernicke's version only. Then there is something known as logopenic aphasia, which is classically seen as Alzheimer's disease. So we have to look about what other symptoms we have. Then, as you mentioned, that corticobulbar tract is something to consider. And even at the level of vocal cords, I would like to see how the vagus nerve is functioning, how the 9th and 11th cranial nerves are functioning. And about the facial muscles, I will also likely to see how the jaw muscles are functioning, the pterygoids, masseter. So the articulation part, the structural and the anatomic part is working properly. So I will also like to see that. And yeah, I guess you have covered almost everything. So now let's see what else we get in HPI. So can you help me around anything that I may have missed?
Fantastic discussion, Kirtan and Maria. I feel like we don't even need to hear the case, Gabrielle. We're just going to talk about aphasia all morning because it's such an interesting topic. And this is just such an amazing discussion. So that's great. When we talk about aphasia, there's a beautiful flowchart. Maybe someone in the chat can Google it. Just Google Blumenfeld aphasia flowchart. Beautiful flowchart. That gets into something Kirtan said. So sorry. So you want to decide if the patient is having a comprehension deficit or a production deficit. So the classic Broca's aphasia, you remember the mnemonic from first aid, Broca's causes broken speech, right? The patient can't speak properly. That can be anything from completely mute, as you would see in a full MCA stroke, to just mild, low frequency word finding difficulty. So our stroke card has a glove, it has a tree, and then it has a cactus, and it has a hammock, right? And so hammock is a very low frequency word for many of us that don't get to spend that much time in a hammock. So it's cactus, unless you live in the desert, right? So patient may say, oh, that's a glove, that's a hand, that's a ball. And then they get to cactus and they say, oh, it's in the desert. It's, oh my goodness, the hammock, they see it, it's a tree, it's 2 things. So that can be a very minor form of a productive aphasia or so-called non-fluent aphasia. And in the middle, you could just get halting, hesitant, challenging speech. That's a Broca's aphasia. And in a pure Broca's aphasia, comprehension should be preserved, right? So you ask the patient to speak, they can't speak or their speech is difficult, but you ask them, show me 2 fingers, they can do that. Close your eyes, they can do that. Showing that the Wernicke's area, which you mentioned was occipital, actually it's temporoparietal, just to clarify that. Temporoparietal region is affected. On the other hand, the Wernicke's aphasia, which in my experience is much less common just because of the way the vasculature is arrayed, is the patient has a fluent aphasia, meaning they're speaking clearly and articulately, but what they're speaking doesn't make any sense. And you might say, well, why is their speaking impaired if their comprehension is impaired? Well, as I'm talking to you, I'm monitoring what I'm saying, right, to make sure it's correct, to make sure I haven't made a mistake. Do I need to fix something I said? Did I say something I shouldn't have said and want to correct it, right? And when that is not working, right, my feedback loop of monitoring my own speech is not allowing me to speak correctly. So I often tell students, if you were to look in the window of a doctor and a patient speaking, and the patient has Broca's aphasia, you would be able to tell from the window without hearing them, the patient is struggling with their speech, they're frustrated. But if you were to see Wernicke's aphasia through the window, the conversation would look normal. The patient is talking and making lots of sounds. Sometimes the words themselves are normal words, but not in any clear grammatical order, and often the patient is not that bothered by it. So that's Broca versus Wernicke's. Those are the 2 common ones to know. As Kirtan mentioned, we can break them down further by whether the patient can repeat or not. So in a pure Broca's, the patient shouldn't be able to repeat because their speech is impaired. A pure Wernicke's, they shouldn't be able to repeat because their comprehension is impaired. If repetition is preserved in either of those, they're called transcortical aphasias and they're named for the deficit. So it's a little confusing. Transcortical motor is a Broca with preserved repetition. Transcortical sensory is a Wernicke's with preserved repetition. And you might say, how can someone be mute but still repeat? Right, that wouldn't work, right? That would be a full Broca. But what you see sometimes is the patient's speech is impaired in a Broca or Wernicke's fashion, but repetition seems disproportionately better than it should be for the level of speech deficit. That's how I think about the transcortical, that when you ask them to repeat, today is a sunny day, or it's cloudy day in Boston, depending where you're practicing neurology, right? You will see that their repetition seems better than their spontaneous speech. And then you could have a global aphasia, and you can even have a mixed transcortical aphasia where the patient's comprehension and production are impaired, but their repetition seems surprisingly good for that. That's a mixed transcortical aphasia. Or just a conduction aphasia where their speech is pretty good, their comprehension is pretty good, but they can't communicate between Broca's and Wernicke's due to a lesion in the arcuate fasciculus, and that's called a conduction aphasia where repetition is impaired in isolation. So those are all just interesting cortical findings that you can tease apart on that exam. And then dysarthria, we'll be able to tease apart based on particular aspects of what the patient's articulatory apparatus is able to do. So for example, some people will have patients say particular syllables and then syllable sequences. So if you say pa, 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 that's okay. Ta, 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 that's okay. Ka, ka, ka. I'll say in a minute, but you're testing different parts of the articulatory apparatus. But then have the patient say pataka, 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 a syllable sequence. If they have some difficulty with the higher order aspects of syllable sequencing, such as you can have in a cerebellar dysarthria or a motor or spastic dysarthria, then you might have the individual components are okay, but the sequence is impaired. And why did I choose pa, da, and ka? Well, pa, 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 pa is a labial sound that needs your lips. So if you have bilateral seventh nerve problems and you can't put your lips together, you can't make a p sound, p sound. And I think I told you this story before of a young patient with Guillain-Barré bilateral facial weakness who learned that when she needed to make the letter P, she would just hold her lips together. So she would say, I was in that place where this thing happened to me, and would do things that way. So pa, 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 labial sound, lips, cranial nerve 7, da, 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 or ta, 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 that's a lingual sound. Ta, ta, ta requires your tongue on the back of your teeth. And then ga, 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 or ka, 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 a guttural sound, right, requires the 9, 10. So we can distinguish between labial, lingual, and guttural dysarthria based on the exam. And then what if this impairment of speech is neither aphasia or dysarthria? I saw a patient recently with a spasmodic dysphonia, which is a laryngeal dystonia where the speech was being interrupted by spasms of the vocal cord. So that's that aspect of the discussion. And then the time course, right, is going to be key here. If we have acute aphasia, acute dysarthria, sudden hyperacute, essentially we're thinking stroke, 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 stroke. The language apparatus is very sensitive. The articulatory apparatus is sensitive. So there are lots of different stroke territories that could cause problems with speech or language. As Kirtan mentioned, sorry, I have a good friend named Kiran, so I keep losing the T in your name, my apologies. Kirtan mentioned in the chronic setting, problems with language can be seen in neurodegenerative disorders. The most common situation, just from a Bayesian perspective, would be Alzheimer's disease. Memory is usually the prominent deficit, but as Alzheimer's progresses, there can be language difficulties as well. As Kirtan mentioned, there are actually primary progressive aphasias, 2 of which most commonly have frontotemporal dementia as the underlying pathology, 1 Alzheimer's pathology, where these sort of mirror the syndromes we're used to seeing in stroke in some respects in terms of the aphasias caused, but they're over a chronic time course. And as you mentioned, there's agrammatic, which is where the patient's grammar is affected. There's semantic, which is more to do with words and their meaning. And then there's a logopenic, where there's just a paucity of speech. And the logopenic is the 1 out of the 3 that tends to have, as Kirtan brilliantly said, Alzheimer's pathology, whereas the others tend to have frontotemporal pathology. And then somewhere in the middle, right? If a patient has some type of, as I think Maria or both of you may have mentioned, meningitis, encephalitis, they're just confused. And if we don't have good attention, right, where our speech will be altered, right? Or herpes encephalitis likes the temporal lobe, right? Could that be affecting the speech as well? Or could you have an abscess in Broca's area, more subacute, a tumor in Broca's area? And then I have seen patients present with aphasia from what's called an ictal aphasia, seizures that are having cortical epileptogenic activity originating from or spreading to areas involved in speech and language. So I think we're out of time and we're done. And that was a wonderful discussion of this chief concern. Okay, so we have a lot on our mind, right? And I like to spend almost half of VMR just on the chief concern because it allows us to review important concepts in neurology and neuroanatomy and clinical reasoning. And now when we go through the HPI, we're just going to be sort of picking things off. Okay, it's acute, it's not acute, right? Okay, it's intermittent, it's not intermittent. Okay, it's language versus speech. And we sort of cruise through. Great, so Gabriella, tell us about this patient more than 3 words. And thank you for everyone listening to our discussion. You have 3 neuro enthusiasts here, and you got us on speech and language, which are fascinating topics for us to discuss.
Yeah, fascinating discussion. Actually, I also like to study language, so this is why I chose this case, because I wanted to see your approach to it, and it was fantastic. HPI, it's a 48-year-old female that presents with an inability to speak that suddenly started one day before. She can comprehend the questions, but unable to produce any sound, just moving her head to say yes or no. Her sister says that she has also been feeling a new headache that started 2 weeks ago, and she came to the ED 3 times in the last 2 weeks when she was prescribed analgesics and muscle relaxants without improvement of the headache. Yesterday, she experienced a sudden worsening in the intensity of the headache when she stopped talking, but she decided to sleep and didn't come to the hospital. The headache doesn't have associated nausea or vomiting, nor photo or phonophobia. She has never had a headache previously. She denies fever, weight loss, or previous infections. Previous medical history, she has major depression. She had major depression and medications, oral combined estrogen progesterone pill. Family history, her sister had deep vein thrombosis and pulmonary embolism. Her brother had a hemorrhagic stroke, and her mother had a mesenteric thrombosis. Social histories, she used to smoke, stopped 10 years ago, and she denies ethanol use. She doesn't have any allergies, and I'll stop here.
Wow, lots of interesting information here. Thank you. Gabby always brings incredible cases from her practice with lots of things to talk about. Kirtan, you're up first this time. What are some thoughts that you have based on this new information?
Yeah, so the fact that the patient experienced sudden worsening of headache after a history of 2 weeks of headache makes me wonder, what if the initial event was a sentinel bleed kind of thing, and then we got thunderclap headache? So what if the patient has like subarachnoid hemorrhage kind of pathology? The fact that the patient doesn't have nausea, vomiting, photophobia kind of argues against the subarachnoid hemorrhage, but still it's an emergency, so we must keep in the back of our mind that subarachnoid hemorrhage is on top of our differential and we shouldn't miss that. Apart from that, I know hemorrhagic stroke can sometimes present as headaches, but still is a little bit less likely. Now, talking about the family history and the medications the patient is on, since the patient is on OC pills, we know that OC pills create a hypercoagulable state, right? I mean, they produce the more fibrinogen from the liver, and the levels of fibrinolysis like tissue passage activator, all the natural fibrinolytics go down by OC pills. So the thrombosis is one of the things we have to consider in our mind. And whenever in family history, I see the thrombosis in unusual locations like mesenteric venous thrombosis, I always think about rare causes. Like what if the patient has factor V Leiden mutation, protein C deficiency, protein S deficiency, antithrombin 3 deficiency, or like prothrombin, if I'm not mistaken, G2021, something like that mutation. So all those hypercoagulable states. And then what if the patient has homocystinuria, right? I mean, the family history is there. So we can get like cystathionine beta synthase deficiency. The levels of homocysteine can crank up and they can cause strokes. So that is something to consider. Apart from that, I would like to see whether the patient, what are the hematologic parameters? Like the patient has polycythemia vera, essential thrombocythemia, or there is evidence of Waldenstrom's macroglobulinemia, all the hypercoagulable, hyperviscous states that we can possibly think about. Apart from that, I guess we can think about paroxysmal nocturnal hemoglobinuria, which can present in this way, but family history is a little bit against this because PNH is a sporadic disorder rather than familial disorders. So all these things are going on back of my mind, but we only have evidence of speech impairment so far. And from the HPI, we haven't got evidence of paralysis or any other symptoms. So it's like hard to think that where the thrombosis is exactly. Is it directly hitting the speech area itself? And there is no evidence of other pathologies or other symptoms. So I will be glad to figure out how to approach that. So now Aaron and Maria, now how can we approach this?
Yeah, great points, Kirtan. So a couple of questions for you to tease this apart a little bit. So you mentioned we have a previous headache, a new severe headache, a neurologic deficit. We would have to think of subarachnoid hemorrhage. Subarachnoid hemorrhage, relatively atypical for it to present with isolated aphasia, right? Because usually the blood is going to be in the cisterns. If you have a distal MCA aneurysm, perhaps you could affect that area, but subarachnoid blood often starts to cause increased intracranial pressure due to non-communicating hydrocephalus. So the fact that, as you astutely pointed out, the patient doesn't have signs of meningismus or signs of altered consciousness make that a little bit less likely. You mentioned this beautiful differential of genetic inherited causes of thrombosis. Of the causes you listed, do you know, sticking to the ones inherited causes of thrombophilia, do those tend to cause arterial clots? Do you know?
Yeah.
So factor
yeah, I mistake that.
and
Usually they cause venous.
they cause venous clots.
Yeah,
right?
yeah. Usually they cause venous thrombosis.
Yeah. And so given that,
and if I'm not wrong, yeah, and I guess only antiphospholipid antibody syndrome is one which causes both arterial and venous consistently. And apart from that, I agree with you that all of them are more likely to cause venous thrombosis rather than arterial thrombosis.
right. So let's take the headache out for a moment. We'll have to contend with that. But when I heard the inability to speak was sudden, we all thought about stroke, right? But if this is a stroke and you have these hints that Gabby is giving us of oral contraceptive use, smoking, and a history of venous clots in the family, how could you get how could you relate venous side thrombophilia with potentially cerebral vascular events? What are one or more ways that could happen?
Yeah. So Aaron, if I'm not wrong, there is something known as cerebral venous sinus thrombosis. And when we get the cerebral venous sinus thrombosis, you can subsequently get hemorrhagic infarction too. So that is one way we can link it. And apart from that, yeah, I am at loss. I think that's what I know.
That's one way for sure. So there's cerebral venous sinus thrombosis. This has been in the news lately, right? With the Johnson & Johnson vaccine, a couple amongst millions having this. We don't know yet if it's related, but talks of vaccine-associated thrombocytopenia in a sort of I'm not a hematologist, but I've seen hematologists talking about this sort of vaccine-induced, sort of just like heparin-induced thrombotic thrombocytopenia. So you can get venous sinus thrombosis. That first symptom is usually headache, raising intracranial pressure, right? And as you said, if there's enough back pressure in the venous system, you could end up with a hemorrhage. So did this patient have a headache from a venous sinus thrombosis and then develop subsequently a hemorrhage at or near Broca's area to give this speech deficit? There's also just in that family, cortical vein thrombosis, right? That tends to present, in my experience, with seizure. And these are harder to diagnose because the veins are quite small and hard to pick up on imaging. But in that family of venous cerebrovascular disease, I don't know about you, but when I was a medical student, I learned the circle of Willis and all these arteries. No one ever told me about the venous sinuses. I learned them when I was a resident. So, right, venous sinus thrombosis could have this history of a worsening headache and then sort of culminating in a neurologic event, hemorrhagic or ischemic. There's another way that venous side thrombotic predisposition or a venous clot could end up in the cerebral vasculature, aside from venous sinus thrombosis. Any thoughts on that, Maria? I know it's guess what I'm thinking. No? Kirtan, other thoughts?
Yeah, so glad you pointed out. Now I think about it, we can get patent foramen oval kind of thing, and that can cause paradoxical embolism. So we can get in that form. And even sometimes when there are pulmonary AV fistulas, sometimes even pulmonary AV fistulas can bypass the venous clot into the systemic circulations. So we have to think about PFO and arteriovenous fistulas in the pulmonary circulation.
Yeah, fantastic. That's right. So if you had venous clot predisposition, right? So when we see a patient, this is a relatively young patient, if this turns out to be an ischemic stroke, of course, we'd be doing our echo, our cardiac monitoring, our vascular imaging, looking for dissection or stenosis. But we'd start to wonder, does this patient have one of the causes of stroke in the young, which could be an inherited or acquired thrombophilia? As you mentioned, with the antiphospholipid antibody syndrome, that can cause both arterial and venous clots. But my understanding, and internists on this session, please correct me if I'm wrong, but protein CNS deficiency, antithrombin 3 deficiency, prothrombin gene deficiency, hyperhomocystinemia are cause venous side disease. And so if a patient has an arterial side infarction in the brain and they have one of these, the only way they could have had a stroke would be some type of connection between the arterial and venous systems. So that would be a PFO, would be a common one to look for. And then you mentioned also patients can have arteriovenous shunting as well. So that wouldn't necessarily explain the preceding headache piece, but just ways that this history of thrombophilia could lead to a cerebral event, either a venous side event, a cerebral venous sinus thrombosis, or an arterial side event if there's a PFO, right? Or Gabby just gave us a lot of incidental red herring information and has nothing to do with this patient, right? So, all right, why don't we, given time, we'll hear the exam maybe and have Maria, you'll discuss the exam. Before we hear the exam, Gabby, Maria, what are you, well, let us know. We didn't talk too much about the headache. I alluded to it a little bit, but whether the headache influences what you're thinking in terms of the differential here, and given that and how it might influence your differential, what you're going to be particularly interested in looking for on the exam.
Well, headaches for me, like when the first sentence that said headaches, I know headaches can cause anything. So the first thing I thought was like complicated migraines, which could still be a possibility, but then there are more morbid and more mortal diagnoses to worry about. So that's like an exclusion diagnosis. And then just like she has no history of migraines, so that would still be rare to have like complicated migraines all of a sudden. But yeah, with the headaches and what we've discussed about venous thrombosis, what I want the most in the physical exam is cranial nerves. Like I need them.
Yeah, and I agree with you. Which ones in particular and why?
Yeah, the ones that go through the cerebral. How do you say that in English?
Cavernous
I'm thinking
sinus.
about it in Spanish. Yeah. So it would be optic movements 3, 4, and 6, and then V1 and V2, which I saw in like an AAN video. That's crazy, you know, sensation being affected here, V1, here, V2, and not here, which is V3. So particularly V1, V2, and then 3, 4, and 6.
Fantastic, right? Great. So I'm glad you brought up the cavernous sinus. You know, it's one of my favorite anatomical locations. I'm pretty sure no one has challenged yet. The only place in the body where an artery goes through a vein. This is a venous structure and the carotid is inside a vein. So to me, just sort of wild to think about. And I'm glad you mentioned that because I think when we learn in medical school about venous sinus thrombosis in the brain, we all learn cavernous sinus thrombosis because it has this complicated anatomy that the USMLE loves, but it's actually a pretty uncommon condition to get cavernous sinus thrombosis. It's much more common to thrombose the other sinuses, which while we're here, why don't we talk about them? There's the superior sagittal sinus, which is a fold in the dura. This is also kind of cool if you've dissected the dura. The dura kind of makes this fold that has venous structures within it. So that's also just kind of anatomically cool. Superior sagittal sinus runs in the interhemispheric fissure in the falx, comes to the back of the brain, is joined by 2 transverse sinuses. They together form the confluence of sinuses, or the torcula of heterophii or something like this, which means wine press, I think in Greek. I don't know why I thought it looked like that. So you have these sort of 3 things coming together, and those transverse sinuses come down to the sigmoid sinuses and then into the internal jugular veins. And now we're back home for the internists who are looking for the JVP there, right? And the cavernous sinus, the internal cerebral veins, basal veins of Rosenthal, there are all these other veins from deep within the brain that go there. And the cavernous sinus is cool, but it's pretty rare to thrombose that sinus. And Maria's right, 3, 4, 6, V1 and V2 are in there. The oculosympathetics are actually also in there, the Horner's quote unquote pathway. But important to note that optic nerve, the cranial nerve 2, is not in there. So you should not have visual deficit here in terms of acuity, just eye movement difficulties. And usually if you have something going on in the cavernous sinus, the eye will look abnormal. The vessels in the eye, the conjunctiva is injected, and that sort of thing. So just to clarify, venous sinus thrombosis, especially that CVST, cerebral venous sinus thrombosis, people get confused that it's all cavernous. Cavernous is just under that umbrella, but a less common. So I agree, we always want to look at the cranial nerves. I think one that I'm particularly interested in here is cranial nerve 2, in particular looking at the fundus, right? Because on our differential, right, is this headache that's pretty acute, right? Not sudden, not hyperacute, but acute, which is concerning, and now culminating in this speech deficit. So if we just back up, we have lots of complexity here. What's in our acute kind of bucket here so we don't miss anything? All the arrows are pointing us at vascular, right? But if we took all this vascular stuff out and said, this patient has had a headache for a week and now has developed aphasia, some other things might be on our differential. Any thoughts, Maria or Kirtan? Just headache for a week, so in this acute bucket, and now aphasia. What would you do with that? Acute but not sudden headache, and then a neurologic deficit on top of that. Definitely some type of, as you both said, venous sinus thrombosis culminating in a stroke or a hemorrhage. That's possible. Maria made the great point that diagnosis of exclusion, right? But migraine can do so many different things. This would be a little atypical for a first migraine to last a week and get worse. But during a migraine, patients can have visual aura before, during, after. Patients can have a somatosensory aura. They can have a brainstem aura with vertigo and dysarthria and all these things. And you can have a confusional aura where patients are actually aphasic. And when patients have their first migraine in older age, of course, everyone is looking for stroke in these patients, and imaging comes back. And then by the time patient's out of the scanner, they have a pounding headache. And we say, oh, wow, you're having a migraine. You look like you're having a stroke, and you can get fooled there. One of the stroke mimics is migraine. What else is on our differential here for headache and then followed by a new neurologic deficit? We have venous sinus thrombosis. We have migraine. The story doesn't totally fit, as Maria said. Other things to put on our etiologic differential here that might guide our exam? What about
so Aaron, I think one of the... Yeah, go ahead.
Go ahead, please. No, I was just going to start giving hints, so go ahead.
Yeah, so maybe I was wondering that what if there is a AV malformation kind of thing in the brain, and that AV malformation suddenly undergoes hemorrhage. So that is one thing to think about. Apart from that, as you mentioned, that we can get tumors. Now, tumors usually cause chronic headaches, but sometimes every once in a while, the tumors can undergo rapid expansion, like let's say glioblastoma multiforme, or what if that tumor undergoes necrosis in the central part and undergoes hemorrhage, then that can cause suddenly a mass effect, and that can cause this aphasia. And apart from that, whenever during our med school, when we were taught about the thunderclap headache, apart from subarachnoid hemorrhage and cerebral venous sinus thrombosis, we were taught about things like pituitary apoplexy. We were taught about carotid dissections, like which can cause arterial embolism like a phenomenon. And if I'm not wrong, it's very interesting because in the extracranial part, you tend to give the heparin thing, but in the intracranial part of dissection, you avoid heparin. So that was one of the things that stuck into my mind during my third year of medical school. So it is amazing that how arterial dissection can present in that way. And usually in those scenarios, we get a history of, chiropractor or something like neck manipulation, like trauma, like fall from a roof or something like that. But sometimes it can happen even spontaneously. We are not sure about that. I mean, there are certain disorders which predispose you to get dissection, like basement membrane disorders, all these thrombophilias and stuff. But still, it's hard to fit in, like as you said, that 2 weeks of history and then sudden worsening. So how to fit it perfectly? So yeah, Aaron and Maria, now help me. What else we can think about?
Yeah, fantastic discussion, right? So a little fast for a tumor, right? But some things are what we call pseudo-acute, right? That they just sort of hit a tipping point. Remember, one of my attendings used to take a pen and roll it on the table and say, look, it's subacute, and then when it falls off the table, it's got acute. So these processes sometimes trickling along and then fall off kind of the edge when they hit a tipping point. So a tumor that's now causing, this is not a stroke, right? Maybe it's causing seizures from, and I've seen one very memorable patient as a resident presented, we thought was a stroke with acute aphasia, was actually having focal seizures from a glioblastoma that was right sitting in Broca's area, unfortunately for her, and was having these aphasia. It was having seizure, postictal, and the Broca's area was sort of disrupted. So a tumor with a hemorrhage into it, a tumor causing a seizure, possible a vascular malformation causing a headache from some type of little bleeding that now had a larger bleed or itself is causing a seizure. We didn't hear about fever or immunosuppression, but I would put the possibility of abscess on the list here. Meningitis with superimposed infarct from vasculitis, right, is possible. You mentioned arterial dissection, cervical artery dissection. So what if this patient's headache is from a carotid dissection that sometimes referred to as thunderclap, but in my experience, often not, just headache and neck pain. You have whatever sort of poorly localized pain around the head and neck from a dissection, right? And the dissection was there a week ago, and now the patient has had an artery to artery embolism. the question of heparin and when and if to give heparin, that would be a whole VMR to, I've actually have a whole noon conference lecture on the conflicting and challenging literature to know whether you anticoagulate or do not for those patients, and whether extracranial versus intracranial matters. I won't go down that rabbit hole, or you'll be looking for me 4 hours later still talking about it. So, but we'll just say dissection with stroke would be another way to link headache that is relatively acute and then followed by a sudden onset neurologic deficit. Other ways to potentially link these, we sort of have every possible category now, from venous side disease, from arterial side disease, tumor, vascular malformation, causing either stroke or seizure. Other thoughts, Maria, anything else? No, okay, so we're going to want to characterize this language deficit on exam, right? Is it aphasia? Is it dysarthria? If it's aphasia, we can go down this flowchart that Kirtan took us down: productive versus understanding, or expressive versus receptive, or non-fluent versus fluent, all the different ways of saying Broca versus Wernicke category. Or is it dysarthria? And then we'll want to see if there's any other clues to the etiology. Does this patient have aphasia and a little bit of a lower face droop on the right side there, sort of helping us understand the extent of this lesion? Is there a pronator drift on that right side? Again, helping us understand the extent of that lesion. Is it getting into motor areas, etc. And then, are there other deficits on the cranial nerve exam? In particular, is there papilledema that would suggest to us elevated intracranial pressure, as could be seen in many of the etiologies we've discussed, but in this overarching context with thrombophilia, particularly venous thrombophilia, with a headache, and with now a new neurologic deficit, hints to venous sinus thrombosis. I'll just say quickly, I saw RCVS fly through the chat. Good for you, whoever started that discussion. Reversible cerebral vasoconstriction syndrome. This is one to be aware of, because the radiologist will say looks like vasculitis, and I always say radiologists can't say itis, they can only say opathy. It's a vasculopathy. Itis, we have to decide if there's inflammation or not, and cerebral vasculitis is very rare. That's a whole nother topic. That's a soapbox for me about not misdiagnosing vasculitis. So RCVS is like Prinzmetal's angina of the heart. You know, I like to make medical metaphors. It's vasospasm of the arteries in the brain, and usually caused by SSRIs or cough medicines or marijuana, or any number of things. It's sort of in the spectrum of PRES, if you've heard of PRES, posterior reversible encephalopathy syndrome, some sort of vasculopathy that's triggered by a number of different etiologies, and can present with thunderclap headache. And if there's associated ischemia or hemorrhage, which can go along with this vasospasm, then you can see neurologic deficits as well. But the picture here of a sort of progressive headache rather than sort of thunderclap intermittent headaches fits a little bit less with that, but important to be aware of, as I didn't learn about it until I was a resident. And once you know about it, you start to see it here and there and see that people are calling it all kinds of different things. So when you mentioned the depressive disorder, I was wondering if you're going to tell us she's on antidepressants, would then maybe make RCVS creep into our discussion, but she's not. Okay. Gabriella, please tell us the examination.
Yeah, okay. So I just want to point that I also tried to ask for many other causes or symptoms before the headache, and like the type of headache, but due to the difficult speaking in the speech, it was very difficult. So, but I really would like to know more about the characteristics of the headache.
Yeah, of course.
So the physical exam, the heart rate was 106, blood pressure 125/60, SpO2 96, respiratory rate 14, and temperature 36.5. In the neuro exam, I'm just going to say the more important things. She didn't have any papilledema, and the only abnormal thing was that she was unable to read, unable to speak, unable to repeat. She was able to comprehend, and she was only able to write her first name when we asked her to write. All the rest of the exam is normal.
Great. So, Maria, what type of language or speech problem is this?
Yeah, I get them mixed up all the time, but so There was this really interesting graph that I saw this week that the most anterior part of the brain was like the most posterior was like perception, and then like the anterior one was like I don't know
Action.
I don't know yeah, but then like it seems that she's able to comprehend everything, which would be like the posterior or like Wernicke, but then she can't do anything with it. So it's what's the word? I don't know what's the word. Like it's Broca's, but I don't know like the description of it.
That's it. Broca's aphasia. That's the answer.
But like, what's the other one? Because it's like Broca's and Wernicke's, and then you get like sensory and
Yeah, there's so many different ways to say, right? Broca and Wernicke's. You're perfect. Broca's and Wernicke's are the eponyms, right? But Broca's is, as you said, either called a motor aphasia or a non-fluent aphasia, or productive aphasia or expressive aphasia. And Wernicke's is called a sensory aphasia or a fluent aphasia, right? So you told us Broca's, which is the name that gives us all of these things after Paul Broca, a French neurologist or neuropathologist, I'm not sure, who saw a patient with aphasia and did the autopsy and said, there's the problem. And hence that area gets his name. Do you know where, since you were starting to tell us about the localization, where in the brain the problem must be if it's a Broca's aphasia?
There's like very specific part of the brain, but like I can tell you like non-specific, so frontal. So in the frontal of you get like Broca's area, and then like that makes so much sense because we have like the motor cortex right there, so that like that connection with the motor cortex makes it like seems that she's unable to read, which is motor. She's unable to speak, which has like a motor component. She's able to write, which is very interesting, but only her first name. But like putting that aside, like it fits like the script.
Yes, exactly. So, and then usually on the left or on the right, this famous Broca's area?
On the left.
Yeah, it is on the left. In all right-handers and in about 90-something% of left-handers, it's on the left. Language is on the left. In some left-handers, it can be more bilateral or even on the right, but the sort of grammatical aspects of language are more on the left, and the musical aspects, the prosody, is more on the right. Yeah, you were going to say, Maria?
I always doubt that, like left or right, because for me, like it's one of those things that I would assume it's right, but then it's the opposite. But then when I say it, it's like, is it the opposite of the opposite? No, it's just the opposite of like what I was thinking first. So left.
Yeah, sometimes helps to simplify language. Left, LL. Language is left in almost all cases. Every once in a while, you'll find a lesion in Broca's, what would be Broca's area, on the right, and the patient is aphasic, and they say, I'm right-handed. And one of my attendings said, oh, ask them where they went to elementary school. And the patient would say, I went to Catholic school. And they said, tell us what that means. And they would say, oh, well, if you were writing with your left hand, the nuns would make you switch to the right hand because you weren't supposed to be left-handed, right? Sinistre, right? Is sinister, comes from left hand, right? And so I don't know what that has to do with Catholic school in particular. I remember seeing my mom take the fork out of my little brother's hand from his left to his right. I said, why are you doing that? And she said, it's hard to be left-handed. All the desks have the desk on the right hand. I thought, wow, mothers have to think of all these things, and wouldn't it be okay if he's left-handed, but he's right-handed, but maybe he was born left-handed, right, and someone turned him to the other hand. So sometimes he says, no, I'm right-handed, and one of my attendings, who some of you have seen in various presentations, Marty Samuels, would say, tell us about where you went to school, and he would say, yeah, in these types of very strict schools, they would not allow students to be left-handed, and so to train them to right-handed. Anyway, I'm sure there are other schools in which, but this was my memory of him always saying, did you go to Catholic school growing up? And why that has to go with particular religion or not, I don't know, but that's the story there. So, okay, the particular area is the left inferior frontal gyrus. And Maria gave us this beautiful description, right? Because the precentral gyrus is motor. That's the one just sending the plan to the muscles. Just anterior is the premotor that's sort of making the plan and giving it. And I think of Broca as a sort of premotor. It's like making the conceptual linguistic plan, and then it tells premotor, you figure out, what muscles need to do this. And then it says, these motor cortex do it, right? So I think of it as sort of premotor. So left inferior frontal gyrus, Brodmann's area is 44 or 45. So we have a lesion there, and the exam confirms that, but we still don't know exactly what it is. So Maria, what test or tests would you like to get at this point to try to figure out what has caused the aphasia in this patient?
Well, this is interesting because, like with any acute stroke, like you would get like a CT first and then like rule out hemorrhage. I don't know, like I don't remember the time course, but yeah, I'd still do that and then move on to like fancier imaging.
Yeah, absolutely. This patient needs a head CT immediately, right, to see if there's hemorrhage or not. And you're right, ischemic stroke can take hours to come out on CT. It can be normal, you can see clues. But yeah, we need to get a first sense with CT, and if we don't have the answer there, MRI, and that's also a management point as well, because if this patient is presented within 3, or in some cases 4.5 hours, and there's no hemorrhage on CT, and we think this is a stroke, and the patient meets other criteria, we can give thrombolytics, right? And if there's a large artery, large vessel occlusion, like the MCA, proximally, or the distal carotid, we could even think of intra-arterial interventions up to 6, or in some cases now up to 24 hours. So the CT is sort of our first branch point, hemorrhage, no hemorrhage, and we go from there. So I agree with you, CT, and if we don't have the answer, maybe vascular imaging and or MRI. So Gabby, give us the next aliquot. Is the next aliquot going to tell us the diagnosis? Then we'll have to put our diagnoses down first. Yes. Okay, so Kirtan, Maria, and myself, let's wager our final diagnoses here. We're going to get some imaging. It's going to be of the brain, right? What do you think we're going to see? I'll go back to you, Kirtan.
Yes, I guess I'm right there with Maria and you that I will first get a CT scan, then get some MRI, vascular imaging studies. And I just wanted to point out that the patient was unable to read also and repeat as well as speak also. So unable to read is, if I'm not wrong, something known as alexia. So like pure word blindness kind of thing. And whether alexia is coupled with agraphia or not, that is whether the patient is able to write something or not. Based on that, we can get our differential. But then everything points to Broca's areas until now. And if I'm not wrong, alexia without agraphia points to posterior part of the brain, like the corpus callosum, the splenium part, and the occipital lobe, in fact. So like how to connect those two dots, that once on one hand we have Broca's aphasia, and on the other hand we have evidence of posterior part of the brain. So I guess that's where I am right now. So tell me, Aaron, what else can we do?
Oh, are you really going to bring up alexia without agraphia at 10 o'clock? Do you really want to be here until noon? Very good point. Alexia without agraphia, what a fascinating condition. I would love to tell you about the first case I saw that and what the chief concern was, but I will respect everyone's time and just say that I suspect here what we're seeing is the patient cannot vocalize what they're reading, but if Gabriella were to write on a piece of paper, close your eyes, that the patient would be able to understand and follow the command. So you're right, alexia localized, alexia without agraphia is a particular syndrome in the left hemisphere of the visual cortex and splenium, or less well-known in the visual word form area in the left inferior medial temporal lobe. Oh, I'm really holding back from talking about this fascinating condition, but I won't do that and keep people from their day and hearing what the diagnosis is. But I think we can wrap that all into the Broca's aphasia here, and I suspect, again, cognitive behavioral neurologists love to do these tests, right, where the patient looks and they can't read, and then to try to prove, can they actually understand what they're reading, they just can't say it, you could write down, close your eyes, show me 2 fingers, and the patient, does these things, and you say, oh, the patient can process the visual information, translate it into language, but just cannot speak it, right? And that would confirm that we're okay with just Broca's area. Any thoughts on what the final diagnosis will be here? We have you could either just give the problem representation, and that might help also, but or just say the final diagnosis that you think it will be. People are saying, please talk about alexia without agraphia. Okay, let's get the diagnosis first so people can go along their day. And then if you insist, maybe I'll talk about one of my million favorite topics in neurology. Okay, go ahead. Diagnosis, Maria?
Yeah, I'm right there with Curtin, like an ischemic stroke of Broca's area.
Ischemic stroke, yeah. Possible, and what would be the etiology in this case, given the headache and the background?
I don't know, like she has some interesting risk factors, so I'm just, I don't know, like thrombi somewhere with a PFO or something.
Okay, so yeah, venous side disease with a PFO and then an arterial stroke, one possibility. Kirtan, do you want to wager a final diagnosis for etiology here?
Yes, I'm right there with you. Venous thrombi with PFO, and if we take out all other things, then let's say they are red herrings. The Gabby has given us red herrings. Then what if the cardiac is not functioning properly? So anything regarding valves or regarding the left ventricle, so probably embolic stroke, ischemic stroke, that's where I'm going right now. Let's see how it figures out.
Yeah, so stroke in the young, if you look, there's a series called the Helsinki study, probably 15, 20 years old, patients 18 to 49, what their most common etiologies of stroke were. And actually the most common are still in this age group, just traditional vascular risk factors, because those are common even as people get into the 40s.
For a series called the Helsinki study of 1,020 years old.
Wow. Go away. I said series. I'm not talking. Wow. That's right. It's like my assistant knows all these neurology words. Know that I said series. What was it? And then she got interested. There was a word I used to say that used to turn my phone on in neuroanatomy class, a neuroanatomical term. I forget what it was. Anyway, no, I'm saying a prior series from Helsinki that the most common etiology of stroke in the young was still vascular risk factors. However, common causes when you take those out are arrhythmias and cervical artery dissection are amongst the most common, and then much less common but worth considering are the hypercoagulable states, right? For me in this case, if we think about our problem representation, right, the headache is important here. And without that headache, I think we'd just be saying stroke, right? But this headache that's kind of culminating in a neurologic deficit, I think made me first think of venous sinus thrombosis with subsequent hemorrhage or stroke, where Kirtan made the excellent point, could this be a dissection and with an artery to artery embolism, but then we'd have to toss out all of these venous thrombophilia things. So I'm wondering actually if this is venous sinus thrombosis, particularly of the superior, no, I won't say the superior sagittal sinus. Broca's is much more inferior. I would probably say cortical vein thrombosis or vein of Trollard in particular. You have Trollard is a little more anterior and Lebet is sort of more in the temporal lobe, but cortical vein thrombosis causing hemorrhage. So I suspect on the CT we'll see a hemorrhage with edema out of proportion to that hemorrhage and perhaps some hyperdensity in the affected venous structure. But if it's an ischemic stroke and the headache has another explanation, that is, as you both said, equally possible. But I'm going to vote for venous disease in this case. Okay, Gabby, what did you find on this imaging?
Yeah, you were right, because the CT scan showed an area of hypodensity in the left parietal region associated with a small area of hyperdensity, which was bleeding. And the CT venous contrast showed extensive acute thrombosis of internal jugular vein, sigmoid sinus, the transverse sinuses in the left. And the CT with arterial contrast was normal, and the MRI also confirmed the thrombosis. We did the investigation of secondary causes, but in our hospital, we only could collect those exams after some days. So she was already started on heparin, but everything came back normal, negative, I mean.
Right, so clues here, right? We have a sudden onset neurologic deficit, right, would make you think of stroke, but the clue here is this progressive headache. You can have headache at the time of a hemorrhage. You can have headache actually at the time of ischemic stroke, though it's a little less common than with hemorrhage, but it can occur. But this progressive headache culminating in a sudden neurologic event really should make us think of venous, even without these risk factors, but the risk factors pushing us there as well. And as it just so happens, last week I made a tutorial on venous sinus thrombosis because it was in the news and people were talking about it, and it's not a common thing to think about. So feel free to check that out. Great, so fantastic case. Gabrielle allowed us to talk in depth about language and speech and thrombophilias and different ways that the vascular system of the brain can be affected, and very timely, as venous sinus thrombosis is very much in the news right now with the possible association, albeit rare, with the J&J vaccine. Great. Thank you so much, Kirtan and Maria. This was so much fun. Brilliant discussions. I hope you've inspired others. And if others are thinking, well, I can't do this, I don't know as much neurology as them. These are future neurologists, right? So they are very keen to know everything, and they are here to inspire you to learn neurology as well. So I hope others will consider being inspired by you and discussing with us next time. I think Rafa is going to give us some teaching points, and then we'll call it a day. And those of us who are scrambling back to the A, and we'll hear this amazing speaker talking about summiting Mount Everest with Raynaud's syndrome, which should be pretty interesting.
So thank you, Gabby. Thank you, Maria. Thank you, Kirtan. Like I was talking with Gabby, like I'm in the middle of these brilliant neurologists and I feel lost. It's like I'm listening to Greek or another language, but I will give my best. So we had these patients with impaired speech, and we can divide that based on a language cognitive dysfunction, aphasia, or a language motor component dysfunction, dysarthria. Time course is very important here. We have to think about sudden or acute causes, especially in the setting of a stroke, or chronic causes, for example, neurodegenerative disorders like Alzheimer's disease. And then when it comes to aphasia, the dominant hemisphere is affected, and mostly on the left if the person is right-handed. And we can have vernix aphasia, which is also called sensory or fluent aphasia. It's a lesion in the superior temporal gyrus, and it's a receptive aphasia with the patient having well-articulated nonsensical speech paired with a lack of language comprehension. And the individuals are not aware of this problem. When it comes to broca aphasia, it's also called motor or non-fluent aphasia, and it's a problem in the inferior frontal gyrus. And the patients can communicate meaningfully, but their speech is low and may be punctuated by pauses in between words as the patient attempts to verbalize each one. And the individuals are often frustrated because they are aware of their expressive language dysfunction. And then another cause of impaired speech is dysarthria, which is a problem with the speech motor component, and many areas above the spinal cord could be affected. So I remind us to think about cranial nerve, nuclei, or maybe the cerebral and other areas as well. And then we had this rich discussion about hypercoagulable states that can lead to a predisposition to arterial or venous thrombosis, depending on the cause. We thought about homocystinuria, protein C or S deficiency, AT3 deficiency, antiphospholipid syndrome, or prothrombin deficiency. But we can also think about pregnancy or contraceptive use, neoplasias, or nephrotic syndrome, because there is loss of AT3 in the urine. And then we talked a little bit about cavernous sinus. It's a collection of venous sinuses on either side of the pituitary, and it can affect the cranial nerve 3, 4, V1, V2, and 6. Many etiologies could lead to dysfunction of a cavernous sinus. For example, carotid cavernous fistula, cavernous sinus thrombosis, pituitary tumor mass effect. And then finally, we talked about headache, which can be primary, for example, cluster headache, migraine, or tension, but also secondary causes. And this case was a case of secondary cause of headache due to secondary to thrombosis. So thank you, everyone. I hope everyone had a good day, and see you guys tomorrow.
Thank you, Rafa. You're very humble saying you were not following this, but actually added teaching points that were things we didn't even discuss, such as nephrotic syndrome leading to venous sinus thrombosis and carotid cavernous fistula. So very brilliant, and the humility along with brilliance is something we prize in virtual morning report community. So fantastic. That's great. Just a quick closing point, Gabby was telling us about the follow-up of this patient, and she mentioned anticoagulating this patient. This is one of the rare instances that when a patient has brain hemorrhage, we actually still anticoagulate them, and there are randomized trials to support this. The venous sinus thrombosis is worse, quote unquote, than the hemorrhage itself in terms of risk for progression. And so you actually hold your breath and anticoagulate these patients with heparin or low molecular weight, heparin acutely, and then with previously warfarin, but a recent trial, I think it is called Respect VST or something like this, for I think it is dagibatran and warfarin. Maybe someone can look it up and correct me, but starting to look at the NOAC or DOACs for this indication. I think it's dagibatran, but I'm not 100% sure. So that is the treatment for this condition. And fortunately, Gabby's patient did pretty well, and most of the time they will do well if you catch this early and anticoagulate them. Although in rare cases, you'll have to have an interventional procedure to try to remove the clot, or if there's very severe elevated intracranial pressure, to treat that complication with osmolar therapy or even hemicraniectomy when it's severe. Okay, Gabby, thank you for bringing a phenomenal and timely case. Maria and Kirtan, brilliant discussion. Rafa, brilliant teaching points. Next Tuesday is the next chance to have this much fun talking about neurology. So I hope you will consider bringing a case, or I hope you will consider discussing said case. And for those of you headed back to the meeting, see you virtually there. Otherwise, have a wonderful day and see you next Tuesday.